Hello everyone, welcome back to my channel, that is Obstetrics and Gynaecology Simplified. Today we will be discussing about a very important topic in obstetrics, that is cardiotocography or CTG. Okay, so this is very oftenly asked as long questions to the final year MBBS students, as well as it may be asked as a short note also. Okay, we have to classify the CTG and also we have to interpret, and also in Viva, also in the practical exams, also in Viva we are definitely asked about the CTG, and we have to interpret, we have to say what are the parameters, how to interpret and how to monitor the patients during intrapartum as well as the antepartum period using the CTG, and what to intervene so that we will have a healthy mother and baby by using the cardiotocography. So let's start. Coming to the first slide, this is the cardiotocography. Okay, CTG slide. See, when is the CTG recommended? See, CTG is recommended in antepartum period and also in intrapartum, during the intrapartum period. So what are the when is the and CTG recommended in the antepartum period? In antepartum period, if there is abnormal antenatal CTG in some period of gestation, okay, or if there is abnormal Doppler in ultrasound, or if there is FGR, also during prolonged pregnancies, if the gestational age is more than 42 weeks, and also in multiple pregnancies. See, these all the indications in the antepartum period you must have been seen in as the index of the high risk pregnancy books. Okay, so these are the indications of antepartum indications of CTG. Okay, when to do CTG during the antepartum period, not during the intrapartum period. Okay, so multiple pregnancies, also breech presentations, APH, antepartum hemorrhage. Okay, then prom and obesity, and if during the early trimesters there is abnormal screening, if the pap is low, okay, low pap A, then the CTG is recommended. Then what are the indications of the intrapartum CTG? The indications like induction of labor, augmentation of labor when we give the oxytocin is given. So if there is tachysystole when we are augmenting the patients, okay, and if there is abdominal bleeding, or if pyrexia is present in the mother, that is temperature is more than 38 degrees Celsius, okay, there we CTG is recommended. And also in preterm labor and abnormal presentation, okay, and also after amniotomy when we do induction of labor by doing the artificial rupture of membranes, then after amniotomy, okay, amniotomy means rupture of the membranes, we have to either induce or augment the labor. So after amniotomy also the intrapartum CTG is recommended, and also during the prolonged second stage of labor. Then what are the parameters? The first parameter is the baseline heart rate. Okay, so the baseline heart rate, what is the normal baseline heart rate? Normal is 110 to 160 beats per minute. This is the normal. Then what is baseline bradycardia? What is baseline tachycardia? Baseline bradycardia means the FHR will be less than 110 beats per minute, but it will be 100 to 110 beats per minute. Okay, so less than 110 beats per minute. So what are the causes? Like if mother is having beta blockers, or hypothermia, hypothyroidism, hypoglycemia. If in case of fetal heart block, in fetal heart block also the FHR decreases, the baseline decreases, it becomes bradycardia, it may become bradycardia. Then suspected acute hypoxia of the fetus. In suspected acute hypoxia of fetus, the baseline heart rate decreases. Okay, it may fall below 100. If the baseline heart rate is below 100, then we are confirmed that the baby is having fetal hypoxia. Okay, and there we have to terminate the mother by cesarean section. Okay, then what is baseline tachycardia? Baseline tachycardia means if the baseline heart rate is between 160 to 180 beats per minute. Okay, then it may be due to fever, infections, maternal hyperthyroidism, also in some medications, and in elevated catecholamines, and also hypoxemia. Okay, during the initial stages of hypoxemia, first there becomes fetal tachycardia and then gradually it becomes fetal bradycardia. So during the initial stages of hypoxic baby, we will see the changes in the baseline heart rate. First there will be tachy and then there will be brady. Okay, and this is an important point. The baseline brady or tachy. Okay, if baseline bradycardia or tachycardia is present, but there is good acceleration, no deceleration, and the baseline variability is normal, that is 5 to 25, then there is no fetal hypoxemia. So it does not indicate fetal hypoxia if the baseline brady with no deceleration, acceleration is present and variability is good. Okay, these are the other parameters. Okay, the deceleration, acceleration and variability are the other parameters of the CTG, including the baseline heart rate. So what are the four parameters? First, the baseline heart rate. Second is the acceleration. Third is the deceleration. Fourth is the variability. Okay. Then what is acceleration? Acceleration is if in more than 32 weeks of pregnancy, in more than 32 weeks of pregnancy, more than 32 more than 32 weeks, if rise in baseline heart rate is 15 beats per minute lasting for more than 15 seconds. Okay, that is the acceleration. And if in less than 32 weeks of gestational age, if rise is by 10 beats per minute lasting for 10 seconds. That is the definition of acceleration. Okay, and acceleration, it is the hallmark of good health, but their absence is a poor predictor. Okay, so presence is the hallmark of good health of the baby, but if absence is a poor predictor of fetal metabolic acidosis. Okay, then the absent acceleration may be due to fetal sleep. Okay, arrhythmias and medications, prematurity, fetal anemia, pre-existing neurological injuries also may lead to absence of accelerations, but that is a poor indicator of fetal acidosis. Okay, pre-existing neurological injuries. Then coming to the deceleration. Okay, third one is the deceleration. So what is deceleration? Deceleration is drop in the heartbeat by, what is the definition? Drop in FHR by 15 beats lasting for 15 seconds. But if variability is less than 5 beats per minute, then but if the variability is less than 5 beats per minute, then drop in heart rate less than 15 beats is ominous. Okay, so what are the types of deceleration? First is early deceleration, then late deceleration, then prolonged deceleration, variable deceleration, and prolonged deceleration. And prolonged deceleration. Prolonged deceleration, if it is lasting for any deceleration that is lasting for more than 3 minutes, is the prolonged deceleration. Okay, so if any deceleration that is lasting for 5 minutes, okay, that and also that will bring down the baseline FHR to less than 80 beats per minute with reduced variability, that is acute hypoxemia of the fetus, okay, or acidosis also. And sinusoidal pattern, that is the sine wave or Castle-Wall appearance, that is indicative, that is an indication of fetal anemia. Okay, this is the sinusoidal pattern, indicative of fetal anemia. Okay, this is the image you see. So what is early deceleration? See, now early deceleration, what happens? This is the uniform shape. Okay, so early deceleration, this is the uniform shape and it is caused due to head compression. Okay, this is the early deceleration. See, this one is the uterine contraction. I have made a proper image. Okay, see, this one is the image I have shown you here. See, this is the uterine contractions. Okay, this is the uterine contraction and this is the early deceleration. Okay, and this is the late deceleration and this is the variable deceleration. So this is the fetal heart rate, normal is 110 to 160 and this is the uterine contractions. Okay, this is the peak uterine contraction and this is the nadir or lowest point of the uterine contractions. Okay, this is where the uterine contraction end. Then see here in the early deceleration, what happened? This is the uniform shape. First, this is the uniform shape and the lowest point of the fetal heart rate, it coincides with the peak of the uterine contraction. It coincides with the peak uterine contractions. See, here it coincides. Then what happens in late deceleration? In late deceleration, this is also uniform shape. Okay, U-shaped, but there is gradual decrease. This is a steep decrease and this is a gradual decrease. And here what happens in late deceleration, the lowest point is after the, see, this is the lowest point. So this is after the peak of the uterine contraction. This is the lowest point. So this is after. Here is the peak of peak uterine contraction. So this is after the peak contraction. Okay, the lowest point of the FHR, it is after the peak uterine contraction. And what about the variable? This one is the variable deceleration. It does not the shape, duration and intensity, it is variable and it does not coincide with the peak of the uterine contraction, so it does not match with anything. In early, it coincides, the dip coincides with the peak of the uterine contraction. In late, what happens after the peak of the uterine contraction, it coincides. But in variable, the intensity, duration and also the shape, it is variable and it is due to the cord compression. Okay, so early deceleration, it is due to the head compression. See this one, early deceleration. See this one. These charts will be similar charts will be shown you in the practicals, and there the questions will be asked. See this is the FHR dip, and it coincides with the peak of the uterine contraction. Here also the it coincides with the peak of the uterine contraction. Here also it coincides. Here also it coincides. Okay, then it is due to head compression. Understood? And what intervention we will do? We will continue to monitor, and no intervention is needed in the early deceleration because it is due to head compression. It is due to uterine contractions. Gradually the contraction will be released. Okay, the uterus will be relaxed, so the head compression will decrease and there will be no deceleration. So we have to do nothing and we have to just monitor, and we have to continue monitoring. Then what about the late deceleration? See, it comes late after mom's contraction. So what happens? See, this is the peak of the contraction, but here the lowest point, it comes after the peak of the uterine contraction. Here also it comes after the peak of, this is the peak and this is after the peak of the uterine contraction. Here also it comes after the peak of the uterine contraction. Then it is due to uteroplacental insufficiency, and here due to uteroplacental insufficiency we may lose the baby, so we have to do immediate cesarean section. Due to insufficiency, blood flow is decreased and we have to deliver the baby immediately. Then what are the interventions? Interventions, we can just augment the process of induction, augment the process of labor by using the oxytocin. We can change the position of the maternal okay, we can change the position of the mother, okay, to left lateral. And also we can provide oxygen, which is non rebreather oxygen also we can provide, and also hydration may help, and also the to we can elevate the legs of the mother to correct the hypotension, okay, so that the blood flow will increase. Then in variable deceleration, the variable deceleration, I've told you it looks like V. See here, it is very steep and it looks like V, but here these are uniform. Okay, these are uniform and gradual. This one is gradual. Late deceleration is gradual, but in early deceleration it is like V. Okay, then what are the causes? The causes is due to cord compression. Okay, so we have to intervene here. See, in variable deceleration, the lowest point of the fetal heart rate, it does not match. Okay, this is variable. Sometimes it is before uterine contraction, sometimes it is after uterine contraction, sometimes it may coincide with the uterine contraction, peak uterine contraction. Okay, so it is variable. Variable deceleration, V for V, and it is V shaped, it looks like V. Okay, this one is V. These are the variable deceleration. So intervention, we can give oxytocin for augmentation, amnio infusion can be done in case of fetal meconium. Okay, and also we can change the position, but usually we do cesarean section. Then, so these are the things in deceleration. Then, what are the pathological variable deceleration? Pathological variable deceleration. In pathological variable deceleration, what are the CTG changes we see? Exaggeration of the shouldering or overshoot. Okay. exaggeration of shouldering, and there may be loss of shouldering. Mild amount of shouldering is normal, but if there is exaggeration or there is loss of shouldering, then it is pathological variable deceleration, and then here we have to do cesarean section. Okay, loss of shouldering, and or there is smoothening of the baseline, FHR, poor variability, late recovery. Okay, if the merging of the variable with the late deceleration together, okay, that is biphasic deceleration. If along with variable deceleration, if the late deceleration is also present, okay, that is the biphasic deceleration. And also if the duration of the deceleration is more than 60 seconds, duration is more than 60 seconds, and depth more than 60 beats, then that is pathological variable deceleration. Then coming to the deceleration is over, then we will learn about variability. Then the fourth point is the variability. So what is variability? The normal variability, that is the beat to beat variability. In the CTG machine, you will be seeing that first in at one time it will be showing 136, next time it will be 135. Okay, the next time it will be 140. So the beat to beat variability is 5 beats per minute. Okay, so that is the variability. So what is the normal variability? Normal variability, it is 5 to 25 bits per minute. Not bits per minute, that is not 5 to 25. Okay, that is the normal variability, and it reflects good variability, good oxygenation. 5 to 25 is normal, and reflects good, that is the normal variability, and it reflects good oxygenation. Okay, and it also predicts the absence of hypoxia. If the variability is good, that means there is no hypoxia. Okay, then what is decreased variability? Decreased variability if less than 5 for more than 50 minutes. Okay, and what are the causes? Causes is fetal hypoxia, fetal sleep, arrhythmias, or any medications, or any like beta blockers. Okay, so the causes are fetal hypoxemia, sleep, arrhythmias, medications. What is absent variability? Absent variability means if the variability is 0. Okay, decreased means less than 5, normal is 5 to 25, and absent means 0. Then what is increased variability? I will just write it down so that the causes I can write. And see, increased variability is more than 25. Okay, more than 25. Saltatory pattern more than 25. And what are the causes? It may be due to, if there is rapid increase in variability, then it may be due to acidosis. Okay, or it may fluctuate. Okay, the variability, it may also fluctuate. First it may become increase, and then later on it may decrease. Okay, so that is the variability. This one is the 2015 revised FIGO guidelines for the intrapartum fetal monitoring using the CTG. This is the CTG classification. So what it say? It says that, say, this is the normal, the interpretation is normal, suspicious and pathological. So the baseline variability normal is 110 to 160, the variability normal is 5 to 25, and deceleration, no repetitive deceleration should be present. Okay, so what is repetitive deceleration? These are, see, decelerations are repetitive when it is associated with 50% of the contractions. Okay, so out of 4, if in 2 contractions there is deceleration is present, so if more than 2 decelerations are present out of 4 contractions, then that is repetitive. That means more than 50% of the times it is associated with the contractions, then that is repetitive deceleration. And if there is no repetitive deceleration, that is normal. And what is the interpretation? There is no hypoxia and no acidosis. So what is the clinical intervention? No intervention is necessary. I have told you, if there is normal CTG or no repetitive decelerations, okay, or even in the absence of acceleration, see here acceleration, I have told you that it is necessarily means it is not necessary that acceleration will be present. In fetal sleep also acceleration may be absent, but that does not indicate fetal hypoxia. It is a poor predictor. So here we are not, even in the normal CTG, here we are not including the presence of acceleration. Okay, so CTG can be normal according to FIGO if the baseline is 110 to 160, variability is 5 to 25, and there is no repetitive deceleration. Okay, in suspicious, if any one, okay, at least one characteristic of the normality but with no pathological features, then that is suspicious. So that is low probability of the hypoxia and acidosis. We have to correct the reversible causes if we can identify. Okay, and close monitoring is required, or if the things are identified, then we can just treat it accordingly. Then what is pathological CTG? In pathological, the baseline is less than 100, so it is in acute fetal hypoxia, it is less than 100 beats per minute. Okay, or if what about variability? There is reduced variability. Okay, sinusoidal pattern or increased variability more than 25 saltatory patterns, and then a repetitive late or prolonged decelerations for more than 30 minutes. Okay, that is also pathological. This is according to FIGO. So there is high probability of hypoxia or fetal acidosis. Okay, and then we have to immediate action to be done to correct the hypoxia, and also adjunctive measures is used, and also if normal delivery is not possible or we cannot expedite the delivery, then we have to do cesarean section. Okay, so immediate delivery here it should be done. Then, so immediate action, what are the immediate actions to improve the immediate actions to improve intrauterine environment if we suspect any abnormal CTG. Okay, if there is any abnormal CTG, so what are the immediate actions or intervention we can do so that we can change the environment? Okay, the intrauterine environment can be changed so that the CTG findings could be changed, or the fetal hypoxia could be reduced, or any reversible causes if identified, we can just reverse the causes. So what are the immediate actions? First, we can change the position so that it improves the, we can change maternal position so that the blood flow is increased and uteroplacental insufficiency can be managed. Change in maternal position. Then we can give nasal oxygen. Then IV fluids, and also stop oxytocin, amnio infusion. See, I have also told you that the immediate actions here, I've told you we can use the oxytocin to improve the or expedite the delivery. Okay, we can use. But here, if we just immediate, okay, just immediate, if we stop the oxytocin, we can reduce the uterine contraction. So, in case of the in case where the CTG shows early deceleration due to head compression, due to uterine contractions, okay, there we have to stop the oxytocin. That is the immediate action where we can improve the condition. Whereas in other cases where we have to expedite the delivery, then oxytocin may or may not be stopped. Okay. Then amnio infusion in case of meconium. Okay. And tocolytics can also be used. In case of excess uterine tachysystole, then we can use tocolytics to relax the uterus and then increase the blood flow and decrease the contractions and hence decrease the chances of deceleration and modify the maternal pushing effects, because every mother does not know how to bear down. Okay, so we have to modify the maternal pushing efforts on bearing down effects. So these are the immediate actions where we can improve the intrauterine environment. Then what are the types of hypoxia? The type of hypoxia is first gradually evolving hypoxia due to cord compression. Then acute hypoxia. Acute hypoxia is due to cord prolapse. That may lead to poor variability also, and also bradycardia and death of the baby, and also abruption and rupture uterus. Abruption and rupture uterus also, that will cause sudden or acute hypoxia. Then subacute hypoxia in prolonged severe cord compression. That will lead to prolonged deceleration and hence later on death of the baby. It will lead to prolonged deceleration. And then chronic hypoxia. That happens in late deceleration due to uteroplacental insufficiency. That is chronic hypoxia. In second stage of the labors, in second stage, 95% of the babies may show the deceleration in second stage. But we have to see the ominous feature in second stage. So in second stage, there are some special ominous features we have to see. So in second stage, what things we have to see, where we will suspect that the CTG abnormalities that we are seeing, that is abnormal. So what are the ominous signs here? The ominous features are poor variability, with tachy or brady. Okay, in the baseline tachycardia or baseline bradycardia with poor variability and also prolonged variability, prolonged deceleration and poor variability and saltatory pattern or sinusoidal pattern. Then what are the causes of sinusoidal pattern? I've told you that causes of sinusoidal pattern is the fetal anemia. So where it is seen sinusoidal heart rate, it is seen in case of fetal anemia in RH isoimmunization. Okay, in RH isoimmunization, in ruptured vasa previa, twin to twin transfusion syndrome, and also seen in fetal intracranial hemorrhage with severe fetal asphyxia. Fetal intracranial hemorrhage in severe fetal asphyxia. Fetal asphyxia. Okay, so this is all for CTG. Thank you and keep learning.